looking forward to hearing from all of you today, and we're going to take all of the learnings from your organizations and use it in the future. And on that note, we want to take a little moment to note that I have sent out learning summary templates to all of you, and we would like all of you to complete those templates for us and hopefully send it back to me by the end of the week. Those are just going to help us compile a report for each of your organizations and sort of get a sort of lessons learned from all of your organizations that we can use and share for other organizations moving forward in the safety net. So with that, a couple logistic notes for today. I know we've had some issues with some people putting the call on hold, so if you guys can avoid that just so we can hear all the presentations today, that'd be great. And then on top of your screen, make sure that the speaker icon is unclicked and that it's white. That'd be great. And other than that, I'm going to let Sam take it away.
All right. Thank you, AJ, and thanks to everyone on the line. Sorry for leaving in session 1. We are on our final session. The date is right, and we're excited to hear from all of you. So you know us by now. And we're going to change things up. We're not going to make 4 Worcester County wait till the end. We're going to go in reverse order. So anyone on the line from Worcester County Health Department, take us through your slides. Nope. Okay. We will come back. Let's see who's next. Gary and Mary West, Senior Dental Center. I think I see Ariel on the line. So, Ariel, let me get to your slide. And then, okay, there we go. And you can just let me know when you want me to advance the slide, and I'll go for you.
Okay. Good morning, everybody. So we're a community dental clinic that provides comprehensive oral health care to low-income seniors in downtown San Diego. We just opened last June, and so we've started to see seniors that typically go to the Senior Wellness Center where we're located. So we're on the 2nd floor there. And so about 800 seniors go to the Senior Wellness Center every day. They provide breakfast and lunch every day of the year, and on Sundays they have a brunch. And so we were created because they were noticing how much difficulty seniors were having eating the meals. And so the way that our model works is we have a team of care coordinators that actually reside in the Senior Wellness Center, and they walk the seniors through a comprehensive geriatric assessment. Then they take an oral health education class with our registered dental hygienist, and they do a basic screening survey, and then they come in for low-cost dental treatment. Most of the seniors are below the federal poverty level, so if Denti-Cal doesn't cover their services, they pay a nominal fee of $10 for treatment. If you want to advance, please. Thank you. So we currently don't have payers who attribute patients to us, and most of the patients, as I said, come from the Senior Wellness Center. But so in terms of looking at attribution, we decided to look a little bit more at the activation side, since that's where our focus is right now. And so we wanted to look at seniors who haven't completed their treatment plans or maybe are missing appointments repeatedly. Our no-show rate is pretty low at about 5%, but there are some of those seniors that haven't continued to come in when they still need additional treatment. And so one of the goals in looking at that data would be to see if those clients are receiving care coordination, and if care coordination is able to maintain that contact and can get them re-engaged with services, either by first addressing maybe some of the other needs that they have that they're not able to access the dental service because of. Some of the clients may be homeless, or maybe they have a physical condition that's going on that needs to be treated before their dental treatment. So I think, we kind of saw this as targeted patient outreach. So we could look at these subsets of our patient population and see what their needs were in order to complete their treatment plan. Okay, next slide, please. So we first started with kind of our what this model would look like if we had full staffing to be able to do it. So we wanted to start with a data team. So they would use our electronic health record system that also integrates with the senior wellnesses system that has the comprehensive geriatric assessment information to identify patients that have missed their appointments or haven't completed their treatment plan. Basically, based on the comprehensive geriatric assessment and the data from the basic screening survey, patients are triaged into what we call our stoplight. So it's red, yellow, and green. And so we would be able to assign a risk score based on what their combination of those stoplights are from the different measures. And then that information would be provided to care coordination. So they would see of those clients that have missed appointments, where were they falling in their risk categories. And so from there, we would want care coordination to contact those patients. And a lot of times, our care coordination team has most success actually going down into the senior wellness center. They're also located on the second floor and catching the seniors at meal times or during the activities that they are doing during the day. And then they're able to bring them to their office and have more of a conversation or set up a time that would be good for them to come back. So we would want them to think about the barriers that those seniors have based on the measures that they had identified in those surveys at the beginning. Also, obviously talk to them and see what their barriers to treatment are and facilitate those referrals or helping with those linkages. And then they can also walk the client over. We really try to emphasize those warm handoffs to the reception staff to be able to make their follow-up appointment and see what would be good for them. So then moving on to the care team, they would schedule for their follow-up visit. At this point, we would probably need to reassess their treatment plan to see what their needs were depending on how long they've been out of treatment, and then schedule those next appointments. Part of this that we also want to work on is really making sure that the care team is communicating back to the care coordination team to have that feedback loop, so that way everyone is on the same page about what's happening with that patient to ensure that they're able to keep coming to their appointments and also getting the other services that they need. And hopefully that would end in treatment completion and then maintenance. Next slide, please. So for us, really working through this exercise, we saw that we really are missing that data staff to help us identify those patients. I myself am becoming more and more familiar with the electronic health record system and how to pull data out of that, but we don't have a data analyst who we can just ask for a report from, and I don't think it would take very much time, but to just have that person that's dedicated to that would be helpful for us. And then again, kind of working through the most efficient ways for the care team to communicate back and forth with our care coordination team, because many times both teams are so busy during the day, and our electronic health records they're integrated, but we don't see them at the same time on the same screen. So thinking about ways that we can make that a little bit more efficient. So that kind of relates to what our biggest challenges are in terms of capacity, which is identifying funds to have more staff and to invest in data systems. And so our next steps, in terms of looking at attribution, this learning collaborative was really helpful for us because at some point the insurance climate might change where dental is more incorporated into government plans, or they might change to kind of more of an attribution model, and we want to be ready for that. And then we also really like seeing the patient activation measurement options, because right now we're measuring a little bit more on the engagement side and would like to incorporate those activation measures into our evaluation. I don't know if anyone has any questions or if you'd like me to elaborate on anything else.
Thank you so much. Any questions or comments for Gary and Mary West team? Okay, and I think we'll go back to our first presentation because I think someone from Worcester County joined. So let me just go back. All right. So Mike, are you on the line? Can you hear us?
Yes, can you hear me?
We can. Thanks so much. You can just let me know when to advance the slides for you.
Sure. So we are the Worcester County Health Department. The Worcester County Health Department is very large. We have nursing programs and a prevention program and environmental health. But I'm from our behavioral health program, and that's really what we've been focusing on. So we do addictions work, case management work, and mental health work all in one kind of big behavioral health program. We do outpatient services. We do school-based services. We have psychiatrists. We're the only provider of psychiatry in the county. Case management and psychiatric rehabilitation services that go out and work with people in the community, and a 24-hour crisis response team. You can go ahead and flip that. You can go ahead and flip to the next slide. Did we lose them? Can you hear me?
Did it? I did. Did it move? Sorry, my computer's freezing.
So our attribution issue that we're trying to focus on here was we talked about doing adults with substance use disorders. I know it's big kind of everywhere, but in the state of Maryland, our governor actually recently declared us in a state of emergency regarding opiate overdoses and opiate misuse. So that's really kind of one of our big target areas right now. So the need is, having trouble identifying and engaging adults with substance use disorders. We have a lot of the folks in our current program are here because they're court mandated or parole and probation sends them. They're here because they have to be. But we want to reach out really and start getting some of those folks who aren't here because they're mandated, but maybe would like to reach out for other reasons. Inform them about our services and try to engage them in services. Because we know they have a lot of different barriers maybe that might keep them from coming in, whether it's stigma or whether it's, maybe they're just not quite ready or maybe they're just not bought into the whole treatment thing. So how do we reach out and engage them? Like I said, we're seeing a lot of overdoses and fatalities. And as we do death reviews on all the fatalities in the county, we're finding that a lot of these folks are not in services, or maybe they're in mental health services, but they're not engaged in substance abuse services. Maybe they, for whatever reason, again, there's some barrier there keeping them out of it. So our, the way we are kind of looking to go about it is using targeted patient outreach. Again, outreaching, engaging individuals who are abusing substances, not just those who are opiate users, but all substances, but really specifically focusing on the opiate use population. You can go ahead and flip it there. I've listed out some of our key players, and these are really the folks who, as we're doing outreach, these are the folks we want to reach out to: primary care physicians, reproductive health, inpatient facilities and detox facilities, the emergency department, the local hospital, and mental health treatment providers, both those who work for us and others that are in the county in the area. So really a lot of this, and we've been working with local primary care physicians and with the hospital, the primary care physicians that operate through the hospital. They're actually getting ready to start using the SBIRT as a substance abuse screening tool. So we're trying to really coordinate, if they do an SBIRT, they identify substance use, how do they get folks in? So we're looking at, developing a targeted referral form and really kind of a smooth, almost handheld process when they identify someone who has substance use disorders. How do we kind of handhold that person into the door? If they're not willing to come in necessarily, can we have case management kind of folks go out there, or care coordinators or peer support workers kind of go out and meet people in the community and try to engage them, use some motivational interviewing techniques, things like that to try to get them in. Same thing like for the reproductive health program, they're getting ready to start using SBIRT. We're trying to do the same thing, just a very kind of targeted, pointed referral form that they can send straight to us, that we can follow up, that we can kind of give them some feedback, just really kind of to really try to build those relationships and coordinate that whole process as easily as possible. Same thing with the emergency department, just trying to make sure we're coordinating with them, making sure that we have resources available to them, that we're getting back to them in a timely manner. And I think that's really the best way we're going to start catching some of these people, getting the right people referred, getting them into the right level of care, that sort of thing. You can go ahead and flip there to the next one. So key takeaways. One of the biggest difficulties that we have is really tracking and organizing our outreach to community partners. You know, our programs are all fee for service, and so, you know, we get very wrapped up in the provision of the service. Doing things like outreach and marketing and this sort of stuff is, you know, is something that, you know, sometimes falls by the wayside, I think, in a fee for service world. So remembering to make sure that we keep a focus on that, understanding that that's sort of a cost that's going to come with, you know, with doing the business, and making sure that we keep focus on that. So the biggest challenge is balancing the outreach and coordination, like I was talking about, with the fee-for-service world. You know, again, very minimal funding for staff and time to focus on those things, but just make sure that remains a focus. And then also tracking the efficacy of outreach and coordination from a financial standpoint. So, you know, one of the things we can do, I think, is monitor how many referrals are coming in the door. But one of the things that I want us to try to figure out is how do we kind of know what our, you know, how well we're reaching out to people and how many people are coming through because of our outreach efforts. That's something that, you know, we'll want to look at from a financial standpoint to see, you know, what are we doing, what's working, what's not working, so we can continue to improve on that. So I think that's our next step really is developing improved tracking and data collection. So that way we know, you know, like I said, what's working, what's not working, what's actually reaching people, and what's not reaching people. I think that's about it. Are there any questions or thoughts or comments for us that maybe could even give us some direction moving forward? Okay. Thank you.
Any comments? Thank you so much, Mike. Any and if you aren't able to speak up on the phone, you can chat a question in, and I can read it aloud to the group too. You can ask questions or give comments both ways. But thanks, Mike. Thanks very much. Okay, is anyone on the line from First Choice? I can't hear you if you're on the line, so we'll come back after. Let's see who's next. Community Health Center of Yavapai. Anyone else? Anyone on the line from Community Health Center?
Yes, this is Kevin Goss. I am with Community Health Center of Yavapai. Hi.
Oh. Hi.
You ready for me to?
Yep,
okay.
Go right ahead.
Okay. Can everybody hear me okay?
We can hear you great.
All right. We just abbreviate our organization to CHCY just to make it easier since it's such a long name. We operate 3 full-time health centers with primary care, pediatrics, family planning, reproductive health, prenatal care, dental, and mental health services. And that is in Yavapai County, Arizona, which is a mixture of small cities and then more rural areas. We are the only federally qualified health center based in Yavapai County, and we're fairly unique, at least we're unique in Arizona in that we're the only county-run federally qualified health center, but we do operate as a partnership between Yavapai County government and Prescott Free Clinic Incorporated, which is a nonprofit, which is our governing board. And last year we served 13,692 patients. And the attribution issue that we're trying to address is that we have value-based contracts with Medicaid plans and also with Medicare Advantage plans, and they attribute a lot of clients or members to us that are not actually patients of CHCY. And so we've identified this as our priority issue because we feel that having so many non-patients included in the denominator for the value-based quality measures may be negatively skewing our results. And so the attribution workflow we've selected is to do targeted patient outreach, and our hope is that this might help us improve patient engagement and improve our results on quality measures for our attributed population. If you could advance to the next, there you go. So this is our attribution workflow diagram, and the goals that we set with this are to schedule appointments for newly assigned Medicaid patients as soon as possible. And it's interesting because our two main Medicaid plans also have Medicare Advantage. So a lot of times these are actually combined, so I should have said Medicaid and Medicare patients. So our goal is to schedule the newly assigned ones for appointments as soon as possible. The second goal is to track patients who are attributed to our practice but whom we are unable to contact or who do not wish to see our providers. And third goal is that this may serve as a resource for future contracts with Medicaid and Medicare Advantage plans. So how we envision it, currently what we get monthly rosters from the Medicaid/Medicare Advantage plans. And then we're going to, our data analyst is going to run reports out of our EHR and compare them with those to see who is new. And then we're going to add those new people to the outreach list. And then that will go down to our care team. And our idea is that they would make 2 attempts to contact the new people by phone. If unsuccessful, they would mail them a letter. And if no response, then we would inform the health plan, and we would send it. The care team would also send that back to the data analyst so he could remove them from future monthly reports. And if we were able to contact them, then we would schedule an appointment, hopefully. If they declined an appointment, again, we would send it to the data analyst to add to the scrub list. If they say they're going elsewhere, we'd let the data analyst know that, but we would also let the health plan know that. So interestingly, through this collaborative, some important things that we've learned has been that in future contract renewals with these Medicaid and Medicare plans, we really need to get some language in there that allows for us to remove patients from our attribution that are actually going elsewhere or that we're unable to reach. So I think that was a good takeaway. And so next slide, please. Thank you. So in addition to that takeaway that I just said, other key lessons that we've learned as a result of the attribution workflow exercise is the importance of centralized coordination for outreach of annual well visits. And actually I would say that really these lessons learned are more lessons learned just from participation in this collaborative. Another takeaway was that organizations that focus on a few key areas to improve tend to see the best success under value-based models of care. Really interestingly, we learned about the ways in which detailed claims data and analysis might help us improve our practice. Like I talked about, the key points to consider when negotiating value-based contracts with insurers, and the value of risk stratification to prioritize patients for outreach. Next slide, please. The biggest challenges we face as we seek to build skills and capacity for attribution, like the dental clinic said earlier, we don't have staff capacity to be really successful right now, we think, in any more than a few strategies. So, like I mentioned down below here, creating some small wins that from being successful on a few strategies that would increase our revenues would hopefully demonstrate to our administrators the value of adding or reassigning staff to be dedicated to value-based care coordination. So that was about all I had. Anybody have any questions for me or thoughts?
Kevin, do you know from a patient or from a member health plan perspective what the process is for a patient to contact the health plan and change their assigned primary care provider?
So normally they just have to call, and it usually takes several days for the change to officially go through in the system, but they do retroactivate it back to the date that the patient called. So, because we often have patients, that want to see our providers that are attributed to other practices as well. Yeah.
Okay. Any other questions or comments? Kevin?
All right. Well, thank you.
All right. Thank you. Thank you to you and your team. Okay.
Thanks.
So next you have Community Care Partnership of Maine. Anyone on the line from Maine? Nope. Okay. Go through. We'll come back. Nation. Amber, are you on the line? I see you.
Yes, ma'am.
All right. Well, there you go. You can let me know when to advance the slides.
Perfect. And I won't read our mission and vision to you, but I will tell you we are a tribal facility, and we were originally operated by the Indian Health System, and we compacted in 1994 to be a tribally operated facility. We provide direct primary care services to all federally recognized American Indian and Alaska Native people. We're licensed for 72 inpatient beds with a daily census of around 35, but our predominant volume is in our outpatient clinics here on our medical center campus, as well as our satellite clinics with over 600,000 encounters a year. Next slide, please. This is just a picture of some of our facilities so that you can kind of get an idea of what we're talking about there. Next slide. These are the boundaries. So in the purple, you will see our 13 counties that we are responsible for, but we most certainly see many patients outside of those boundaries within our state as well as our surrounding states. Next slide. Next slide, please. Thank you. So to get into our project, some of our attribution challenges. When we first started our grant and the implementation of our MIDAS software, we really were looking for a way to determine patient acuity, and we wanted to do that so that we would have the most robust empanelment process we could, and from that, impact our quality outcomes by impacting our patient flow, and ensuring we had the right level of providers seeing our patients, and things like that. So our priority issue was to ensure that patients are empaneled to the appropriate provider level, our physicians versus our mid-levels, and to ensure we had an adequate number of providers to meet the needs of our patient population while ensuring quality outcomes. So the risk attribution workflow that we've selected was the risk stratification in a retrospective form. And if you'll advance the slide, please. Here's sort of our diagram. So we wanted to apply this risk map module, and we're using the MIDAS software to do that. And through that, through screening of various indicators, an interface with our EHR, and then claims data, assigning a patient weight to each of our patients, and then empaneling them based on that weight so that we can have a more diverse and appropriate panel based on these patient acuity scores. So how that impacts our registration team, what we're looking to do is instead of just assigning, a 40-minute appointment to new patients and a 20-minute follow-up for recurring patients, really assigning appointment times based on their acuities, and also scheduling follow-up appointments based on their acuity. So instead of just taking a standard approach of, every 3 months or every 6 months for a follow-up, really tailoring their follow-ups to their acuity level. And being able to forecast that helps us to see how many open slots any given provider would have for walk-ins or new patients. And that way we can see whether or not we're at max capacity or if a certain provider has room for new patients and things like that. And so what that does for our care team on those higher acuity patients, instead of just having certain screenings done annually or every 6 months, on those higher acuity patients, we're increasing when the screenings are due within our EHR to a more frequent basis to try to keep a better eye on some of the things that our higher acuity patients might have going on. Next slide, please. This is an example of a panel that we've ran in MIDAS. This is more relative to our inpatient population, but does flow into our impaneled patients for outpatient. This is the algorithm that MIDAS uses and to assign a relative weight. So it's taking a look at the risk of readmissions, expected complications, their expected length of stay versus their actual length of stay, the risk of mortality, and then again, the risk of readmission, and that first one was adjusted based on severity. So based on that, they've gotten a relative weight, and what we do with this on the inpatient side, we have a public health nursing team. So those people that are at higher risk for readmission and have a higher relative weight, those are the priority for our public health nurses to go and see. We schedule their follow-up appointment before they leave at an earlier frequency than others. And then we also have some unique options and resources available to us as far as transportation and things within the Chickasaw Nation. And we work with those other departments to ensure that those patients take priority when it comes to scheduling appointments and ensuring transportation is available to get them to their appointment. So it kind of just helps us manage our resources better, not only within the health system, but the entire Chickasaw Nation, and kind of helps us know where to prioritize and focus on. Next slide, please. This is another example. This is in our primary care, and we took a look at the subset of providers to do a diabetic study. Our software helped us do this, and this is one of the many things that go into our outpatient impaneled for patient acuity. So this is taking a look at, the software ran the number of patients in that particular provider's impanelment that have diabetes, the percent that had a documented HbA1c, then of that, the percent that was controlled and uncontrolled. And I know that those two numbers don't add up to 100%, the controlled and uncontrolled. And where that comes from is the logic behind that is the percent of controlled is less than or equal to 7. That's the value our provider set. And then the percent of uncontrolled is greater than 9.5. So there's a range of there's a range within there that is assigned a different weight than a controlled or uncontrolled would be, sort of varying depending on if they're closer to controlled or closer to uncontrolled. So those are some of the things that we're doing for attribution and to help us manage our panels and our population based on clinical factors, either actual clinical factors or predictive clinical factors that our software is assisting us with. Next slide, please. So some lessons learned and key takeaways for moving forward. We have realized that this is a great tool and a great thought process for managing our currently impaneled patients, but because it's retrospective, it doesn't provide us a way where when a new patient walks in that has never accessed our system to how we're going to impanel them. So we're starting with, we will impanel the new patients based on weights and have to re-look at the patient acuity at some sort of routine frequency. But that hasn't been established for us yet, but it's on our radar of things that we need to consider. And then also just how we acclimate new providers to this system and the expectations of how they manage one acuity versus the other. Some of our biggest challenges are just identifying the metrics and the methodology that we want to use in addition to MIDAS to fit not only our inpatient setting, but our outpatient and ER settings, and having the appropriate buy-in from all people, all parties that have a piece of this. And that concludes my presentation. Oh, next slide. I do have lessons learned, one more. Sorry about that. Running all of these patients through the patient panel acuity process, and just determining our ideal staffing ratios based on the population. So when we are asking for another provider or asking for another mid-level or nurse or pharmacist, whoever it might be, a member of the care team, that we really have data asking about that, to ask for that. And where that comes from is if we know at what frequency every patient needs to be seen for routine follow-ups in regards to their patient acuity, we really can start taking a look at scheduling and time slots to see how many available slots are open. So we really feel like we'll have a more robust defense for either whether we're understaffed, overstaffed, and be able to forecast moving forward so that hopefully we can keep ahead or in line with the movement of our patients and not always be retrospectively responding. And that really is it this time. Are there any questions?
No, this is Amanda from Starling. I just wanted to say this issue of the retrospective attribution is a big issue, and it has not only does it impact sometimes your ability to really identify the patients for interventions, but it can also have an impact on how your reimbursement model is set, when they're looking at, if the payers are looking at, for example, retrospective benchmarking and things like that. I'm just curious if other folks in the collaborative have had this issue and how have they worked around the retrospective attribution issue. I'm just curious how other folks have tackled that. Okay. I just wanted to see if you had some safety in numbers there, because I know that's a tough model sometimes to work with. So I appreciate that. I also really want to acknowledge something that I've heard a lot of people talk about, which is this idea that, thinking about what the staffing models are going to be to help support the intervention models that go along with this. I think that's another issue. And goodness, we've had so many different discussions with groups over the last several months. I can't remember where we talked about this, so we may or may not have talked about it in the attribution session, but we get frequently asked, to help groups come up with sort of an ideal staffing model, and it's really, really challenging to do that, and a lot of that has to do with the fact that, your patient populations all look a little different. Your relationships with other part of the system that you're trying to interact and engage with may look a little different depending on, you've already had examples of like behavioral health and dental and substance abuse, and so it's really challenging for us to say here's the cookie cutter model for the correct staffing configurations. I think what I would just reinforce as you guys are thinking through this, as you're implementing these models, is to really be aware of what your fully loaded costs of all your staff are. If you're in a position to be negotiating with payers or with other service providers who can offset some of your staffing costs, really think through kind of what the ideal state of staffing would look like, so you're not shortchanging yourself. I think the biggest challenge we see is that people are like more inclined to be more conservative, and it's fine if you don't get everything that you need from the payers or from your system partners in terms of supporting those costs. But I think really learning how to drill into what's going to make your model of intervention successful. Where can we look to partner on some of the data capacity? Because I think a couple of groups already have talked about some of the challenges with building the capacity on the data side to be able to do this work effectively. Again, there might be shared resources that you can partner with, either with your payers or with some of your other hospital partners, for example. But anyways, I didn't want to distract, but I've been reflecting now on the last couple and thinking about some things that I thought, I kind of heard thematically that I wanted to hit on. And if anybody comes up with a magic bullet on the care team or staffing models, let me know, and you and I can go into business together and sell it and make lots of stacks of gold as we impart it on the rest of the safety net. But I think
so far, I'm really just struck by, a lot of the things you guys are talking about and where we see some of the challenges, but also those challenges provide opportunities really for you guys to be creative in your intervention and workflow design. So thank you.
Okay. Thanks, Amber and Amanda. And I think someone from the main team, I think the main team is ready, so I'm going to toggle back. Sorry, I didn't give everyone motion sickness. Okay. So are folks on the line from Community Care Partnership of Maine?
Yes.
Wonderful. Thank you. Let me know when to advance the slides for you.
Sure. So we're Community Care Partnership of Maine. We're an accountable care organization made up of 3 community-based hospitals and 8 FQHCs across the state of Maine, so from the northern part to the southern part of Maine. We have about 72,000 attributed lives in the various payers that we're working with. And our primary focus really is on the quadruple aim. So reducing cost, improving clinical care, having a really good patient experience, and improving and maintaining provider and staff engagement and satisfaction. The next slide. So our attribution challenge and the issue we're sort of trying to address is the number of Medicare patients with what we would consider excessively high utilization of healthcare services. We identified this primarily as our issue to try to lower the cost of healthcare and really make sure that they're getting their needs met, the patients that we're identifying, and then also ensuring that the setting that they're getting their care is really the most appropriate. We're going to be using the targeted patient identification and outreach workflow. Next slide. So this is actually one of our reports that we're going to use through the Medicare Shared Savings, and we actually saw this, I think, in our first session as a group. We are identifying those patients with 21 or more primary care services, so we figured we would start there, and it looks like we have about 621 patients in our ACO who we would consider could or might have high utilization. So we're going to start there. We'll talk a little bit about one of the challenges with this, but this is a really great sort of aggregate level report, but there's really no ability to drill down on that. So we'll talk more about that later as one of our challenges. Next slide. So this is our workflow diagram. So we first need to sort of engage our data analysts and start looking at the data. So if anyone's ever seen the Medicare Shared Savings data, it comes in individual files. So you might get an entire file of hospital utilization, and then a file of medications, and a file of DME, and they are all separate. So it requires someone really to aggregate all that to look and find those patients who are the 621 that we just mentioned. So it really is very time intensive. It requires someone with some more advanced knowledge than myself or my team to be able to identify those high utilizers. So once they aggregate all the data, we're hoping that those reports or that report would go to our performance improvement coaches, and they would start reviewing charts. Obviously, 621 charts seems like a lot, so it's going to take a while, but we'll start with sort of the highest of those 621 first. So they're going to review charts for anyone with more than the 21 visits, and if they're really just considered to be high utilizers, they'll put in a referral via standing order for care management. If some of those eligible patients appear that they would be most appropriate for palliative care, and we'd be using our predictive analytics tool that we use through our health information exchange called Health Infonet, and it looks at mortality risk in the next year. So we would identify anybody who had sort of a high mortality risk as well as the more than 21 visits, and discuss with the provider and see if they would be appropriate for palliative care. And if the palliative care was felt to be appropriate by the provider, we would place the order for palliative care and reach out to the patient with the provider. If palliative care wasn't felt to be appropriate, then we would refer to care management. And again, our hope is sort of to get managed care out of this model, get them to the most appropriate setting, and really engage patients overall. Next slide. So some of the lessons learned in doing the exercise is we need to get IT more involved in this to be able to collate all of those files we talked about. We really need some more redundancy in running these reports and sort of assigning to a particular person and sort of once a month so that they're run routinely and the data is given to our care managers and our performance improvement coaches. And really, by looking at it, we had a lot larger number of patients that we would consider higher utilizers than normal, than what I had expected. Some of our biggest challenges I had mentioned, just accessing the data, really analyzing the data to look for trends, the time that it's going to take to do this work, limited expertise really in Medicare shared savings, and I find even trying to engage Medicare in helping us do this, they're challenged as well. So we're all sort of learning at the same time, I feel. And then just really the inability to find that drill down aggregate data. So what would be most useful is to be able to click on that 621 as a number and really just give those patients to us right then. It would be much more user friendly. Our next steps, again, involve IT, start training staff on using and analyzing the data, develop the workflow, which we kind of already did, and then just start implementing standing orders for care management. And that's all I had. Any questions?
Yeah, I have a question. This is Amanda from Starling. Because you guys are a multi-organizational ACO, but you're looking at a common patient population, I'm just curious as to, we worked with a lot of groups that are in that model as well, and I'm just curious for the group's benefit, if you could sort of share what your process is for, kind of taking a population health approach across so many different organizations. So, which of these functions do you think are important kind of at the centralized level? And then what do you think is important for the individual care teams and at the practice level? Like what's been the difference in how you guys have had to approach those two kind of structural elements of the ACO?
Yeah, that's a good question. So primarily the data aggregation, the data analytics, that really can be done at the practice level, at the sort of the total organizational level, at the ACO level, pretty effectively. And the practices really don't want to engage in that sort of work. So we don't feel like we're sort of stepping on toes by trying to do that. It does get really sticky. It's been interesting to allow our performance improvement coaches and our data analysts and some of the other staff that work at the ACO level, trying to get them access to the individual EMRs to be able to do some of this work has been really challenging. And I was actually sort of surprised at how much pushback we get in trying to do that. So for us at this point, I think until people get really comfortable with one another, most of the function of the data analytics aggregate stuff will be done at the organizational level, and then the actual reviewing of each patient will probably still happen in the practices. It would be much more efficient if we could do it at the organizational level, but I feel like we're still going to get pushback on that.
Yeah, that makes total sense. I think that's pretty consistent with what we've seen as well. So, hey, thank you.
Okay, is anyone on the line from Cherry Health?
Yes, Kayla is here.
Hi, Kayla. Go ahead and let us know when to advance the slide.
Okay. So I am from Cherry Health. We are a federally qualified health center in Michigan. We have about 70,000 patients at this time. We provide quite a few services. We have medical, behavioral, dental, vision in our West Michigan area. And then we also have re-entry programs via the Federal Bureau of Prisons in the Detroit area. So that's about 12 sites in the greater Grand Rapids area including the outlying rural communities in Montcalm County, Berry, and Eaton County. Next slide, please.
Hold on one second. This is Amanda. I'm trying to get it to advance.
Okay.
Sam and I had to do a handoff on the advancement, and AJ, is it possible for you to advance? I've lost my ability to do that. I'm going to whoops, there we go. Hold on.
Yeah, no problem. I'll get it.
Oh, hold on. I got it. Whatever you did just now was magic, and it gave me the option again. Okay, there we go.
Okay, so we have been working with various insurance companies for a while with different attribution data, but the most recent challenge we've had, and the one I'm most familiar with, is due to a project we are rolling out at our sites. We're about a year in, and it's called My Care Team. This is part of Section 2703 of the Affordable Care Act, and it opens up funding for health home models. So it's really hitting that integrated care piece a little bit harder. We have 4 of our sites participating in this project. We have our Wyoming Community Health Center, Durham Clinic, Adult Med, and Westside Community Health Centers. So the state of Michigan sends us lists of qualified people for My Care Team, and it's about 1,300 people long, and it's about to get even bigger because they're taking it from 12 months retrospectively to 18 months. And some of the people are our patients, some are not. What it does is identifies people as qualified for our My Care Team if they are in Kent County, and if they have either anxiety or depression diagnosed, plus hypertension, heart disease, diabetes, COPD, or asthma. So those are the patients we're looking at, and they have to have Medicaid, and they have to be over 18. So in this list of 1,300 people, we have Z-scores to identify how risky of a patient they are, and it additionally identifies the number of ER visits they've had and inpatient stays they've had over the 12 to 18 months time frame. So we have the dubious distinction of having the patient with the most ER visits in the state of Michigan on our list. So we're really dealing with quite a bit of chronic individuals. And it's just hard dealing with all these different sites and all these different patients. Where do they come from, and just sorting through that. In that data, some patients are just assigned to the wrong site. Sometimes we don't have that even, what do I want to say? We don't have that figured out at our organization level because some of our patients like to bounce around between sites. So it just gets difficult to deal with all of that data. But ultimately, we have to get it right. We are in a year on this study. We have the health homes funding is really the future of healthcare. It's rolling out across the nation. So we really want to get it right. And we are below our enrollment goal. We're at 33% of our enrollment goal over the 2-year project. So we would definitely like to see that a bit higher. Okay, next slide. So we selected the targeted patient outreach attribution workflow. We feel that we've already captured the low-hanging fruit, so to speak, so we're moving on to people who are a little bit more difficult to engage. And that's probably pretty representative that we're at about 33% of our qualified patients. So our patient population, I already went over that. We get our data from the state of Michigan, like I said. We also have access to a system called Care Connect 360 that a lot, but not all of our insurance companies put information into. We have a waiver support application, which is through the state of Michigan. We at Cherry Health use NextGen EHR that we can pull data from. And Viper is a system that deals with ER visits. So we have a lot of ways to access our data and a lot of ways to manipulate the information we have. So our data team can help us with some of these systems, but ultimately it comes down to the nurse care managers who are on our My Care team. They do a lot of that data management, and then myself as Health Homes Coordinator will do that as well. And anybody can access it. We've granted access to all of the data programs to everybody that's on the care team, so we don't have to rely on the data team necessarily. Next slide, please. Our registration team, they can work the prioritized list to schedule, reschedule, and track no-shows so that we're hitting that part of patient engagement. We'll also set up new appointments with any people who are not within the Cherry Health system, which we have to be very careful, of course, of not enticing patients or disrupting patient-provider relationships that are already working for somebody. Just because they're qualified for our program doesn't mean we necessarily want them in our program if they're already happy where they are. And then the care team role is really huge. Most of the responsibilities for attribution and engagement fall on the care team. So we have a nurse care manager, a behavioral health therapist, PCP, and community health worker. That's the core team, and then whoever else we need to engage. So we have to pitch my care team appropriately. We don't want to scare anybody off with our pitch. We don't want to sound like a salesperson. We want to make it sound like we're trying to provide better care. We have to identify patients already engaged at the site but not enrolled in my care team and reach out to them. We also want to identify the patients who are not at Cherry Health but might actually benefit from coming to our My Care team service. And then we want to provide integrated care to these high-risk patients. So we also have to do care coordination and working as a team at the same time. Next slide, please. So these are the lessons that we've learned. The low-hanging fruit are easy, and then after that, it gets really complicated. And sometimes just looking at that huge list of over 1,000 patients makes it even just seem very daunting. Also, staffing deficiencies in other areas are impacting our ability to follow through at every stage. So, you know, if we're short on nursing staff, our nurse care managers end up doing that duty, even though their duty is really specifically for my care team. And then our organization, we have so many patients and sites and processes that it gets complicated too. We're really striving for standardization, but that doesn't happen overnight. So we still do see some complications in that regard. So I think one of our best steps to build capacity for attribution would be to work in a routine process and to enhance patient engagement. I think it would be great if we could really fully integrate and get our behavioral health staff working to identify the patient values so that we can engage them around goals that are going to work toward improving their health. I think that's my last slide. Yes, thank you very much.
Great. And not sure. Looks like we might be at the end. I'm just trying to double check. AJ, I see your note there. Just to make sure we didn't. Is there anybody who's on the line that we didn't get a chance to get to yet? Okay, well, with that, I just want to really acknowledge the important work that you guys did to get ready for today's presentation. We realized we asked you to do a little bit more work than maybe you thought you were planning on doing as part of this final presentation, but we really appreciate it, and it's really helpful for us to be able to sort of see how you guys have been thinking through some of these models for your particular situation and have been able to pull down examples of that hopefully your peers have found helpful as well. I think with that, you know, on behalf of the Starling team, what I really want to just say is thank you. You guys have been a great group to work with over these last 6 sessions, and we really anticipate and hope to stay in contact with you guys as you guys are moving forward on this journey. We know that attribution is the first step that many of you are taking in terms of putting together these more complex care models and really thinking about how to engage differently with other parts of the system and payers and the patients as you're moving forward in a value-based reimbursement. So we really appreciate that. We're continuing to be here for you as a resource as you move forward, so please feel free to reach out as you see fit as you're going forward. And I think with that, I'll turn it over to AJ to see if you have any closing comments.
Yeah, I just want to echo pretty much what Amanda just said. Thank you all for all your great work throughout these 6 sessions, and I'm happy to facilitate any connections that you might need moving forward. Anything that we can do, maybe any connections you need that you think will help you as you combat payment reform and the safety net, we're happy to be of help for that. So with that, I want to thank you all, and we can call it early today.